We think this is a quite what we're going to be looking at today is how data systems can be improved, ultimately with the objective of forming better policy. We think this is quite we're going to be profiling some kind of emerging practices. This is quite a new area. So we want this to be a very interactive session because we all think this is not something where anybody has got all the right answers, and that we want to learn from each other. Great, next slide, please. Yeah. So I want to start off with why are we here? What is the problem that we have with our health and finance data systems at the moment? And two of the key problems are firstly that the data is not presented in a timely way. And a second key issue is that these data systems are siloed. So we might have a financial management information system. We might have DHS to record our health outputs. We might have an HR information system, but we can't join these up to get a full picture of how the inputs into the health system are producing the outputs. So these are some of the issues that we want to discuss today. And one of the kind of underlying reasons behind these problems are weaknesses in data governance. So this is some data that the World Bank has gathered. We can see that only 40% of countries have a unified chart of accounts across both their central and subnational governments. So that has implications for how they can track financial flows, but also then implications for how you can join up financial data with other data. And on the right-hand side, we can see that many countries are struggling to link their spending data to the outcomes we care about, whether that's SDG outcomes or other key performance indicators. So these are some of the challenges that we have at the moment that we want to take on and learn from today. And so how can we strengthen health information systems and their use in policymaking? We're going to learn from Burkina Faso, Ethiopia, and Uganda, who are investing in new digital ways of working to improve their health financing data. We're also going to learn from Ghana about the potential for improved analytics to inform policymaking once data can be joined up. We see this session as very much a first step towards building a network of practitioners and documenting promising practices and emerging lessons. So if you are undertaking some of these reforms yourself, whether in a government or supporting government to do so, we would love to hear from you during the session, and please do get in contact with us after the session, as we see this the start of an ongoing set of work for us. So we want to kind of foster peer learning and generate a broader understanding of both the possibilities, but also the challenges in implementing new digital approaches to health data systems. So a quick run through of what the program is going to look like this morning. So we're gonna start off. Once I finished here, we're first going to hear from Anamutayalu, who is from the Ministry of Health in Ethiopia, and the work that they're doing on enhancing the tracking of financial resources for health. We will then hear from Ali Walimbwa and Andrew Kwiringira from the Ministry of Health in Uganda about how they're trying to develop a financial module for DHS2 to improve the monitoring of facility spending. And we will then hear from Dr. Dimitri Otwara from the Ministry of Health in Burkina Faso about their work on developing a digital ecosystem. We'll then have a chance for a discussion and raising questions to the panelists and raising your own experiences. And we'll then take a short coffee break before reconvening when we will hear from Dr. Hamza Ismaila from the Ghana Health Service on their work on analysing the allocation of personnel across government health facilities. And we'll hear from Maritz Piatti from the World Bank on technologies for health financing needs in Eastern and Southern Africa. And we'll also hear from Martin Atella, the Director for East Africa at ID Insight as well. And again, we'll have chance for discussion and for you to raise any questions on your own experiences. And we'll then have some closing reflections from the organizations that have co-organized this session, from Ern Brady at CHAI, from Mary-Regina Foss at Thinkwell, and from my colleague Danielle Cerebro from ODI and from Cadbury. Final slide. So I want to thank all of our speakers for speaking today, because, as I said, this is an emerging area. And usually when people want to present projects, they want to present the shiny, finished building. But today, they're not doing that. They are presenting work in progress. So our presenters are sharing the work that is ongoing. And I think that this is the kind of how we want to run this session, is that this is work in progress. There are emerging lessons. These are not kind of fully finished, fully successful projects. And we want to share the challenges and lessons as we go along this road towards realizing the potential of new digital technologies for informing better policy in the health sector. So thank you very much. I hope we have a lively discussion here today. And without any further ado, I want to hand over to Animat, who is, I hope, joining us online.
Thank you. Can you see my slide?
We can see them well. Thank you.
Okay, thank you all. Just I would like to thank the getting the opportunity to present our financial management experience from the Ethiopian context. Now, just to introduce myself, I am Animut from the Ministry of Health Ethiopia. Now I'm Health Financing, Economics and Partnership Team Lead. Now I'm here to present the tracking of financial resources for health in Ethiopia. Just to give you a highlight or background information, this is the Ethiopian health system landscape. We do have the three-tier health system. That is the primary healthcare level, secondary healthcare level, and tertiary healthcare level. The primary healthcare level, it includes the health post, which is located within the community, and the health centers and the primary hospitals. The health post is assumed to provide or to serve a population ranges from 3,000 to 5,000 population. And the health centers, we look into the health center into the rural and urban context. The rural context, the health center expected to serve a population ranges from 15,000 to 25,000. And the urban context is, as you know very well, just the urban context is densely populated. The health center is expected to serve 40,000 populations, whereas the primary hospitals is expected to serve a population ranges from 60,000 to 100,000 populations. Whereas the secondary level hospitals, that is the general hospitals, which is expected to serve a population of 1 million to 1.5 million populations. Whereas the tertiary levels, that is the specialized hospitals, which is expected to serve a population of ranges from 3.5 to 5 millions populations. This is simply the Ethiopian healthcare tier systems. And as a background information, Ethiopian population is estimated to have about 120 millions, of which 80% is living in the rural areas or rural context. The average life expectancy in Ethiopia is 67 years. That is compared to the low-income countries. We are in a good track. And the maternal mortality rate per 1,000 live births is 267, which is also in a good track. By 2030, we are expected to reduce the maternal mortality per 100,000 below 140. So just we do have 5 remaining years or period. Just we are in a good track to achieve our SDG targets. when we see the healthcare professional ratio to the populations, it is 1.32 per 100,000 I mean 100,000 populations. I mean 1,000 population, which is this case is all forms of healthcare professionals. Actually, when we see the national targets by 2025, that we reached or increased to 2.5, actually we are out of track. And as we see, the time is 2025, we're out of track on this. Regarding the community health workers, more than 40,000 health extension workers are deployed within the community at the health post levels to serve, mainly to provide the preventive and promotive services, plus to the curative service. When we see the health facilities, we have more than 22,000 public facilities. In separate is more than 18,000 health posts located in the community, and health centers almost 4,000, around 4,000. And the primary hospital is 270, and the general hospital is 108, and the special hospitals 28. These figures are excluding those health facilities who are currently under construction. This is a health financing landscape, the Ethiopian health finance. That's actually when you see the diagram, it's a bit, it seems a bit complicated, but it is simple if you realize the flow. Ethiopia has the three funding channel systems. That the first one is if you see the cursor in the top corner from the right side, this is the channel one resource funding. That means the resources are managed through the government system, that is Ministry of Finance. That means, again, the channel one is also channel 1A. That means annual market funds, and this channel 1B, which is earmarked funds. When we say earmarked, resources or budgets are allocated or dedicated to a specific outcomes or projects or any program aspects. With certain criteria or allocated formulas, the government allocates budget to regions. Just for your information, Ethiopia has a federal state government. Where currently we do have 40 regional states and 2 city administrations. Therefore, there are allocation budget or resource allocation formulas. That is with what you call it in our case, just hydration formula. Based on that formulas, we allocate resources. So the channels with the Ministry of Finance allocates fund to its regional counterparts, the Bureau of Finance and Economic Development. And again, Bureau of Finance and Economic Development allocates budget with its own criteria to the Woreda Finance and Economic Development, and also the secondary care level, that is the general and referral hospitals. And the Woreda Health Finance and Economic Development, again, with some allocative criteria, it can allocate resources to the primary care, that means the primary hospitals, health centers, and healthcare levels, and also provide in the form of products, that means medical drugs or medical equipment, or in terms of salary. Again, we come to the Ministry of Finance, again, it transfer to the regions, again, it transfer or give resources to the tertiary care, that means the federal, university, and specialized hospitals. This is the first one. The second one is channel to resources, when resources are managed by the sector, that means the Ministry of Health, and mainly was the health pool fund, the SDG pool fund. Again, this is also channel 2A and channel 2B, that means under-market and earmarked resources, with definitive criteria, allocation criteria. Again, the Ministry of Health also allocate funds to its counterparts, and the regional health bureaus. And again, regional health bureaus with definitive and with certain criteria, again allocate resources to secondary care, that means the general and referral hospitals, and again to allocate resources to Woreda Health offices. And Woreda Health Office again allocates resources to the primary healthcare level, which is the lowest unit of the health facility. And again, the Ministry of Health again also allocates resources to the tertiary care, that means the federal university and the specialized hospitals. And the last one, the third one is this channel 3 resources. In this case, the resources, the government doesn't directly control or oversee the resource allocation and disbursement. The resources are managed by the implementing partners, which is commonly known as the CSOs or civil society organizations. Donors are given their monies or resources to the implementing partners, and the implementing partners are managed themselves, I mean, their resources by themselves. Only the implementing partner provide technical assistance to the government. Only the government role in this regard is just to review the implementing partner's proposals in a way to align with its priority or the government's priority. And once we approve the proposals, and once we approve the proposal and get into implementation, during the course of implementation, the government will also monitor and evaluate its implementations. Commonly, the government or the Ministry of Health, I can say the Ministry of Health can conduct the midterm and end-term project evaluation or project implementation evaluation. This is all about the health financing landscape in Ethiopia. In short, as a background information, just we have conducted. I mean, we will have an HE exercise for the last time. Just we have conducted 8 rounds of national health account study. Now, just by using or referring the recent national health account study, the health the per capita health expenditure is around $36, which is by far lower than the WHO minimum recommendation, which is $86. The total health expenditure as percentage of GDP is what, 6.3. When we see the share of the development actors to the health expenditure, that government contributes 32.2% to the total health expenditure, whereas the development and the donors contribute to 34% of the health expenditure shares mainly supports the maternal health, child and HIV and TB and malaria. And then the last one is the out-of-pocket or household expenditure, which is around 31%. It's still very high. We need to work on to reduce or squeeze the out-of-pocket expenditures. And most importantly, the resources, government resources are allocated or directed to the primary healthcare level in a way to reduce the urban and rural disparities. When we see our financial management, which is the focus critical area for this session as well, currently we have a different mix of capturing the financial data. That means we mix a different mix of manual processes. We do have multiple data entry systems, and there are fragmented reporting systems, which will hamper data visibility or to get real-time data. As you see the figure, just as I've told you before, just Ethiopia is the federal state government. That is the federal, regional, Woreda, and also as facility levels. Financial resources are managed at the federal level. We see that there is FMIS, that means Integrated Financial Management Information Systems. And also we use the pitch tree, which use especially for channel to resources, and also resource mapping. We conducted, we conducted annual resource mapping and expert tracking. The development partners or the donors are committed or shows their commitment or their pledgement to support the health sectors on annual basis based on the resource mapping templates. In this case, just if you see the channel to resource data is received in Excel format and manually entered into IFMIS and P3. This is manual based, and also when we see the channel 1 and or treasury budgets, data converted from IBEX to IFMIS again. Because this at federal level, IBEX is not implemented in federal level, that is IBEX is implemented at subnational and below. When we see also when we see the regional level, that IBEX is there also, just pitch tree is there. When we see the data entry, the channel to multiple instances of pitch tree, that's all fragmented and not standardized again. And also when we see the treasury or channel 1 resources, data sent from IBEX manually. And when we see the Woreda level, that IBEX is there is Excel and paper-based, which is manual. And again, when we see the facility-based, that is Excel and paper-based as well. And the channel to resources in the Woreda level, the channel to the data sent to the regional level as an Excel file to be manually entered into P3. It is manual, it's somewhat tiresome. Again, we see the treasury, that's the channel 1, the data sent through IBEX again. When we come to the facility level, channel 1 and channel 2, both channel 1 and channel 2 resources, is paper-based data entry. and disseminated to the next level through either email, Telegram, or WhatsApp, or any other communication platforms. With all these challenges and with those challenges we encountered, we are expected to generate reports like what consolidated budget report, liquidation status report, and statement of expenditure, and then history reports and grant reports as well. All these challenges and the existing challenges, we investigate that the root causes of limited data visibility or financial data visibility. The first one is data silos. Since we have different systems, data are fragmented or independently managed, and there are redundancy and duplication of financial data. Since we have a manual-based and also multiple entries, there will be redundant and duplication of data, and also inconsistent and insufficient data. And also there is limited infrastructure and manual processes, especially for remote areas. The infrastructure is very limited, and also it is unable to capture financial data from remote areas, and also fragmented governance and coordinations. As I have told you, Ethiopia is a federal state government, and regions are autonomous by themselves. They pass decision independently. So that due to this arrangement, there is a fragmented governance and coordination. Due to this, there is limited financial data visibility. From all these challenges and the existing situations, we recommend a new directive for digital transaction will improve a real-time tracking of financial information or data. Just you have seen the existing situations but now we recommend that the situations that we are aspiring to happen is that two standardized data exchange. With this system, just we try to integrate the existing data to interoperable or to be interoperability and reducing duplications and streamline data to data entry to closer to the source, and also linking the health sectors to the government's public financial management strategies. As you have seen, the system is here that the federal, regional, orada. That means the IFMIS and resource mapping also. And here we introduce the new systems. Whenever the need arises, a new system that needs to be implemented, the data standard is, the data integrator system is a system agnostic. That meaning it can adapt or accommodate any systems whenever we need to implement within the system. So by creating a common digital registries, which means the standardized data attributes across the system, that means from the IFMIS, resource mapping, and also other data. By creating the data adapters, that means translates the existing systems into a common language or a common definitions or a common exchange platforms. By using it, just we can create data exchange layers. That means common or integrated data. This digital platform also captures the service delivery data. That means the DHIs too, and procurement and other also deliveries we can accommodate, and we can get the financial data only in one dashboard or one system. Once we do this, there will be data analytics and visualizations, and the outcome will be we will get timely and accurate data reporting and liquidations, and also the reduced reporting burden using the government systems. And also it improves financial management for efficient utilization of existing resources. If we utilize the resources at hand efficiently and effectively, it will be the premises or the precondition to mobilize additional resources from donors and other philanthropists. So just once we in place the data integration system, that is the standard-based data exchange systems, we will get accurate data or timely resources or for decision makers. Having the integration data, the standard-based data captures and exchange allows reduced duplication and improved analytics and streamline outputs and reports. It will create in the future just Once we in place the integrated data or health tracking system or financial tracking system, health financing data is captured consistently in all systems across all the levels of the government. What will happen? The approach is creating common digital registries. That means standardized data definitions shared by systems or different systems, and create common formats. That means the program, administrative hierarchy, and geography, and others. And it allows different systems to speak to each other. That means by creating different, common language or definitions of data, it can speak to each other's. And the second one is redundant data capture is eliminated or almost minimized. And we will get disaggregated data available from some national levels. It will happen or put into practice through what financial events are captured close to the source. IBEX or another future accounting system is evolved. Adapters enable data to be shared across systems and labeled seamlessly or unifiedly. Duplicative data entry is eliminated. That means the financial data is only entered once. With the existing systems, there are duplication of, there are multiple entry of data. When once we integrate the data or the data platforms, data will enter only once. And the third one is the data is routinely used for decision making, for program planning, for resource allocation, for execution and reporting as well. It will be implemented or practical through data exchange layers for seamless physical information flow. And by combining data across systems and level for analysis, in future, analyze service data and financial data together, and easy and quick financial reporting for different stakeholders, especially for channel to resources. And the last one is can evolve existing systems or integrate the new system to address emerging needs. As I have told you before, once we improve health resource tracking or integrated or standardized database systems, it is the system agnostic, or it can accommodate a new system. Whenever the need arises in the system, it can accommodate a new systems. It can be practical through a digital public infrastructure to enable the digital systems. That means common infrastructure created of common registries, shared standards, and granular services and financial data can be linked. Operation can be digitalized. The new systems and transactions can be integrated to just about the insurance systems or any digital payment systems and the like. This is all about my presentations. Thank you for your listening. Can you hear me?
We can hear you, Anima. Thank you. That was a fantastic presentation. And I think we really appreciate the detail of you setting out the current fragmented systems across the Channel 1 and 2, the resources that go through the Ministry of Finance and directly to the Ministry of Health, and the vision that you've set out to transform that to an integrated system across, and I think highlight making use of common data registries and shared data standards, and the potential that gives both for joining up the financial data, but also joining that up with service delivery data. And once you've got those kind of common data standards, being able to integrate any new systems that come online as well. So Anima, thank you very much for that fantastic presentation. And I now want to hand over to Ali and Andrew from the Ministry of Health in Uganda. So if we could have the next presentation up, please. And Ali and Andrew, please come up to the front.
Thank you so much. I'll be introducing my colleague, Andrew. As part of the background, this is a tool that we developed from the Department of Planning, Financing and Policy, Ministry of Health, Uganda. It combines the process of planning, budgeting, capturing financial information, but also links to information sharing, including monitoring and evaluation. The gap previously was that we're focusing on a small component. We also realized that there is need for us to have a very comprehensive system. So in addition to that, reporting from the lowest facility to the center was a challenge, and that's why we also added the component of how do we put it in the DHIS2, and this is what the presentation is all about, and I will hand over to my colleague to take us through. Thank you so much.
Thank you, Adi, for that introduction. We are waiting for the presentation, then we start rolling out this tool. Then we look at the pilot of this tool and also look at the description, a quick overview of the sections or thematic areas within that tool. And we look at the process of data capture and how Ministry of Health utilizes this tool. Next. Next. So since 2000s, the health facilities were responsible for planning and budgeting under direct facility financing reforms. But until now, this process was entirely manual, relying on paper-based submissions. So we had all health facilities aggregate the data into their paper-based forms up to the district. Then you have the districts also aggregating these paper forms and submitting them to the Ministry of Health annually. Of course, that means that other external partners, you do not have access to that information. But also when it comes to like analysis, if you want to see longitudinal performance, you are not able to do that because the information is scattered in the papers. So but also this tool was comprehensive. It had a lot of information on human resource management. You have information on supply chain, on paper forms. And yet we realized that most of this data is available within our systems. And you heard from the introduction of our chair, the main issue is us having many systems, parallel systems. So we thought that we could utilize this opportunity and integrate all this data from multiple sources into one form. So we had to reduce this form so that we can be able to, for the data which is already digitized, we'll be able to utilize it and we cut it off from the paper. Next. So the review of this form aligned with the entire review of HMIS, the Health Management Information Systems. Until July 2024, we had used the entire HMIS for 5 years. So every 5 years we had to review. We have to review all these forms. So we got this opportunity to also tap into this form and review it. So we went through all these processes at the national level in a consultation with the sub-national teams at the district level, the district health officers. We are able to, and the health partners, we are able to agree on some of the main themes that we need to adopt going forward. And whatever is in the other systems, we are able to cut it off and utilize it within the system without having to duplicate it on the paper. So after that, when we agreed on the major themes, we now embarked on piloting. But this pilot was alongside the other HMIS tools to try to get the user acceptance experience and also that experience from that huge paper-based. Previously it was about 20 pages, but we've now narrowed it to about only nine pages. So what we've done is develop a module within the DHIS2 that to be able to capture all of this information that was previously captured on the paper form. So we plan to roll out this form starting the financial year 2025-2026. And we've planned a lot of activities, on-site mentorships for the to improve the utilization of this form and all other HMIS tools. We plan to conduct these activities just before the rollout of this tool. Next. So both districts and we are now going to the description of the form. Yeah, would have been able to demonstrate how it is captured in DHIS2, but it would require us to just keep dropping down. But this is just to give you an overview of what is within that form. So at the district level, we have the district biostatistician can enter the data at that level, but also the health facility, the records in charge, can also be able to enter this data within that module of DHIS2. So you note that this form will capture specifically, you can get the funds, the budget approved versus what was released alongside different sections. You either like a wage at the level of a health facility, the sources of the funds, whether from the partners, from the central government, they are able to capture that information at their level. Next. Within beside that, we also have a work plan within that module. So within this work plan, the facilities are required to submit this work plan at the start of the financial year. Then on a quarterly basis, they are supposed to submit a report on the performance alongside the key activities. And these activities, not just that they come up with their own activities, these are activities which have been set forth by the national planning, the national planning strategy under the PIAP, the National Development Plan. So you can see that is an example of one form, the previous paper form, which was coming from one of the health facilities. So one of the districts. So the districts had to submit it to the Ministry of Health. And like the earlier said, it would mean that this information is only available to the Ministry of Health Planning Department. So once we roll out this form, the digital form, it will also follow now the entire health management information system process. The way it is, the data will be captured. It means that we do not need now to outsource for like records officers who are going to be entering the data. They will use the existing structures to be able to enter the data. But also means that whatever advance, every other day, we have a new advance in the DHIS2. So which come like analytic applications, advancing. So it means that as we advance with all those modules that are coming on board, it means that this form will also be able now to ride along all those developments. However, the health center 2s and health center 3s, all these lower health facilities do not enter data direct into DHIS because of limited the infrastructure. They do not have electricity, you do not have computers, but even the human resource at that level does not allow them to enter data direct. So what they'll do is still collect the data on their paper forms, but they can be able now to go to the nearest health facility, like health center 4, which has DHIS2, and they can enter the data direct. And that is how it is done, like in the entire HMIS process. But at health center 4s, general hospitals, even regional referrals, they going up, they have DHIS2, they will be entering the data direct. And just the same process, like I had earlier said, still these other focal persons will be able to validate the information in the data before it is accessible to other stakeholders or MOH. So we are required that at least at every reporting timeline, the schedule, these officers are able to validate the data. If there are any issues, they are rectified before the data is published for utilization. Next. So we chose the DHIS2 has a number of modules, but because the data that we are capturing within the plan, this tool is not only quantitative where we are only reporting figures, it also has the qualitative aspects. We have a section within there where the oversought analysis, they're able to identify their strengths, the weaknesses, and the opportunities. And so we had to choose the tracker capture, which allows for the qualitative data entry. But generally, the beauty with the DHIS2, we already have the validation rules implemented for these tools. So if there are any issues of the data quality or any outliers, they can be flagged for people to review or correct the data. But also mainly the interoperability improvements. Like I had earlier mentioned, this paper tool required that you provide information on like human resource management. How many cadres of are available within your health facility. But because we have now an advanced human resource management information system, the IRIS, we are now able to now integrate it here so that the health facilities do not have to use this paper form, but this information is already provided within other systems. But also the user enhancements when it comes to the interface of the data entry, and which keep improving with the DHIS2 advancements. Next. Like I earlier said, that the rollout of this tool is not in isolation with other HMIS processes. So we have undertaken the data quality assurance mechanisms with the other HMIS tools, and which are also cross-cutting to this tool. So what we have done, we have automated the validation rules within DHIS2, that if you enter maybe data which is out of range, it's able to flag for you who is entering the data that this is this and this, please cross-check the data. But also we have, the main issue has been on the providing feedback. So we have put in place some feedback loop mechanisms. We have now automated a data quality report. So we expect that they are going to be reporting on quarterly, their performance on a quarterly. And you have a schedule when you are supposed to be reporting, maybe like the 15th of March. So we have a window when the system is open for you to be able to clean. So we will be able to generate this report. It is sent on a mail of all the across all levels. If I'm in a particular district X, I get that report for that particular X for all the data quality issues which will be which have been identified, so that they can be corrected, and then the system is closed and we have a report. We'll then, of course, have these other supervisory checks routine at the health facility to improve the data quality. Next. So these are some of the experiences with the pilot. The tool was well received because it had a smaller volume, now 90 pages from about 20 pages. But also the health facilities lower level, they are still continuing to use the paper. We wish that at least the infrastructure and the internet and the computers, the personnel extend there so that they can also be digitized. So this is how we we've been using the information, the data from the paper, but we think that it becomes more efficient when we have now digitized. So on the aspect of health system planning and resource allocation, we are specifically, it will facilitate the development of recruitment plans for different votes. You are able to identify human resource gaps and be able to now plan accordingly. And performance monitoring and accountability, we are able to now track the functionality of health facilities and either upgrade or downgrade. If you are performing to a level of a health center 4, when you are a health center 3, maybe the catchment area has increased the population, we are able now to upgrade you and then allocate resources appropriate for that level. Then, of course, we'll be able now to track the progress of approved work plans, activities. Again, these work plans will be submitted at the start of the financial year, and every quarter we are now able to monitor the performance. Thank you for listening. That is our presentation.
Thank you, Andrew. That was a fascinating presentation, and I think really interesting to see how you're making use of existing digital systems to try and integrate the financial reporting from the facilities into that. And I think some of the points you made about the challenges of rolling this out to all facilities that may not have IT facilities, that may not have internet access as well, I think provides real food for thought in some of the real challenges in bringing the digitalization across the health system as well. So thank you. We're going to have one more presentation before we go open up to Q&A for all the presenters so far. So I'd like to welcome Dr. Dimitri Ouattara from the Ministry of Health in Burkina Faso, who is going to be presenting for us online. So I hope that we'll be able to see him up here shortly. And Dr. Dimitri will be presenting in French. So for those of you that are not French speakers like myself, if you go onto the AFIA app and click on the session, the link is there for the translation if you connect. So Dr. Dimitri, welcome. Thank you very much for joining us this morning. I know it's been quite an early start for you from Burkina, and please take away your presentation. Thank you.
D'accord, merci et bonjour à tout le monde. Donc, je voudrais commencer par remercier les organisateurs de cette conférence qui nous donnent l'opportunité de partager l'expérience du Burkina Faso dans la gestion des financements au niveau des soins primaires. Donc, c'est un travail qui est fait par une coordination d'acteurs, dont des acteurs du ministère de la Santé et des acteurs, des partenaires techniques et financiers. Donc, je suis juste celui qui présente. Donc, la présentation va s'articuler autour de ces systèmes que nous avons appelés écosystème digital minimal au Burkina Faso. Donc, je suis Ouattara Jean-Serge Dimitri, directeur des systèmes d'information du ministère de la Santé au Burkina Faso. Dans les axes que nous proposons pour la présentation s'articulent autour de 4 points. Donc, en premier point, nous allons revenir en fait sur les progrès en matière de soins primaires au Burkina Faso ces 20 dernières années. Ensuite, nous allons présenter les justificatifs en fait de la mise en place du projet écosystème digital minimal. Nous allons présenter ensuite un état de la mise en œuvre de l'écosystème digital minimal et terminer par des réflexions par rapport aux leçons déjà qu'on peut tirer et des perspectives qu'on peut avoir par rapport à l'écosystème digital minimal. Donc, il faut dire que depuis maintenant 20 ans, le Burkina Faso enregistre des progrès assez significatifs au niveau des soins primaires, qui sont liés à des réformes majeures qui ont été entreprises. Donc, comme réforme, il y a la politique de la gratuité des soins pour les cibles, en fait, santé génétique, santé maternelle, néonatale et infantile. Il y a aussi la mise en œuvre de la stratégie de la santé communautaire qui permet de prendre en charge un certain nombre d'actes de santé au niveau de la communauté. Et il y a par exemple des campagnes pour la lutte contre les endémies comme le paludisme à travers la chimioprévention du paludisme saisonnier. Donc, ça a permis en fait d'augmenter et d'améliorer les indicateurs au niveau de la santé génétique maternelle, néonatale et infantile. On peut par exemple citer le taux de mortalité maternelle qui est descendu de plus de 500 à moins de 180 pour 100 000 naissances en 2021. Nous avons aussi la planification familiale qui s'est nettement améliorée en améliorant aussi les soins de santé sexuelle et reproductive. N'empêche, il demeure toujours des défis. Et les défis sont liés à une fragmentation en fait du système d'information au niveau des soins primaires. Donc, cela est caractérisé par un ensemble d'outils digitaux qui existent déjà, mais qui fonctionnent en silo et qui ne permettent pas en fait d'avoir des données de qualité pour la prise de décision et pour une gestion efficace des ressources allouées aux formations sanitaires. Alors que l'État contribue fortement en fait avec des subventions aux formations sanitaires, nous ne sommes pas capables en fait de savoir si les financements sont équitables, si on arrive vraiment à soulager les populations à la base. Donc, cela a conduit à un certain nombre de réflexions qui ont amené à mettre en place ce que nous avons appelé écosystème digital minimal. Donc, l'écosystème digital minimal, les objectifs principaux étaient de répondre à la problématique de la fragmentation du système d'information. Donc, arriver en fait à faire collaborer entre guillemets les plateformes pour qu'elles puissent produire une information qui permette en fait une gestion efficace des ressources allouées au niveau des formations sanitaires pour que le financement de la santé soit équitable et aider les décideurs aussi à anticiper et à planifier aussi l'allocation de ces ressources. Donc, dans la pratique, l'écosystème digital minimal a plusieurs composantes. Donc, dans la composante applicative, nous avons environ 8 outils digitaux qui étaient déjà existants. Un outil, par exemple, pour les registres de consultation au niveau des soins pour l'enfant, un registre de consultation pour les femmes enceintes et le suivi, en fait, de la santé génétique, un outil pour la gestion des dépôts pharmaceutiques, un outil pour la gestion des flux financiers, ainsi de suite. Donc, nous avions un certain nombre d'outils qui existaient, qui s'adressaient à des fonctionnalités particulières, en fait, au niveau des soins primaires, mais qui ne collaboraient pas. Donc, l'écosystème digital minimal va faire en sorte que tous ces 8 outils-là soient déployés dans toutes les formations sanitaires. Ça, c'est la première composante. Ensuite, l'écosystème digital minimal doit travailler en sorte à faire monter les données d'indicateurs de ces 8 outils vers un entrepôt et y bâtir un tableau de bord qui va permettre d'avoir un outil efficace de visualisation pour les décideurs. Et il y a aussi des aspects de documentation et de recherche liés à l'écosystème digital minimal. Donc, cela a commencé, on va dire, en début 2023, avec des réflexions d'abord au niveau du ministère de la Santé, ensuite élargies aux partenaires techniques et financiers. Et vers mi-2023, on a mis en place un cadre formel qui a permis de commencer, en fait, les activités de l'écosystème digital minimal. Donc, 2 districts, le Burkina Faso compte 70 districts, mais 2 districts ont été choisis, un district dans une zone, on va dire, périurbaine et un district dans une zone rurale, pour être des sites pilotes de mise en œuvre de l'écosystème digital minimal. Donc, de juillet 2023 à, on va dire, à juillet 2024 pratiquement, on s'est concentré à s'assurer que tous les 8 outils étaient déployés dans ces districts, dans toutes les formations sanitaires des districts. Donc, c'était des activités de déploiement, de formation des acteurs, de supervision, de coaching pour l'utilisation de ces 8 outils. En parallèle, il y avait un travail, en fait, pour bâtir un entrepôt en fonction des indicateurs qui avaient été définis pour chaque outil et un tableau de bord aussi pour la visualisation pour les décideurs à tous les niveaux de la pyramide sanitaire. Donc, en juillet 2024, presque tous les outils étaient déployés dans toutes les formations sanitaires des 2 districts pilotes, sauf un seul outil qui n'a pas pu être déployé dans un district. Et en novembre 2024, l'État a voulu étendre en fait l'écosystème digital minimal à la région du centre, qui est la région où il y a la capitale, pour essayer de voir un peu l'impact que cela pouvait avoir au niveau régional. Parce que les 2 districts étaient dans des régions distinctes et les leçons tirées se limitaient en fait au niveau district. Donc, on envisage à partir de 2026 de faire un déploiement dans tous les autres districts pour avoir l'impact au niveau national. Mais déjà, on a quelques leçons qu'on peut tirer en fait de cette initiative en croisant les données des différentes plateformes. On arrive à suivre en temps réel un certain nombre d'indicateurs pour la gestion, par exemple, des dépôts de médicaments, la gestion des flux financiers au niveau des formations sanitaires, et aussi la gestion de la facture, en fait, de la subvention à la gratuité des soins. Donc, les leçons qu'on peut tirer de façon formelle, on peut les classer, on va dire, en 4 grandes parties. Donc, nous nous sommes rendus compte rapidement que pour que ce genre d'initiative marche, la coordination entre le ministère de la Santé et les partenaires techniques et financiers est un point clé. Donc, il faut vraiment un alignement pour permettre, en fait, de mettre en œuvre en synergie les différentes interventions de santé numérique pour pouvoir capitaliser les données et pour pouvoir aussi, dans la mise en œuvre, économiser sur les coûts par des formations ou des supervisions intégrées. Donc, tout de suite, on a eu l'impact sur les formations parce que les 8 outils sont portés souvent par des acteurs ou des partenaires techniques même qui sont différents et chacun faisait les déploiements de son côté avec les formations. Donc, nous avons vu qu'en combinant, en intégrant les formations, les supervisions et en mettant même en place des dispositifs pour pouvoir le faire de façon systématique, on était plus efficace et on arrivait aussi à mobiliser beaucoup plus les acteurs au niveau des districts. Donc, une autre leçon tirée, mais qui est déjà connue, mais qu'on a corroborée, c'est l'importance de l'infrastructure informatique, en fait, pour tous les projets, en fait, de digitalisation. Donc, le Burkina Faso n'a pas l'Internet dans toutes les zones, donc ça a été un gros défi à supporter. Et la question aussi des équipements à mettre à jour, à acquérir aussi a été un gros défi. Et enfin, et ce n'est pas le moins important, nous nous sommes rendus compte que la difficulté d'utilisation des plateformes n'est pas forcément liée elle-même. Elle peut être liée même à la littératie numérique même des utilisateurs. Parce que les acteurs au niveau périphérique ne sont pas toujours sensibilisés au numérique. Donc, il faut envisager peut-être des formations au numérique avant d'introduire des outils numériques pour la gestion du système. Donc, dans la suite, ce qui est envisagé, c'est d'arriver à bâtir une architecture de notre système de santé qui va permettre en fait d'avoir une couche d'interopérabilité standard centrale selon les normes, bien sûr, standards, et d'aligner en fait toutes les sources de données pour qu'elles soient compliantes à ces standards-là, de sorte à pouvoir pousser les données dans un entrepôt et faire en fait des analyses plus poussées. On envisage même d'intégrer en fait l'intelligence artificielle pour pousser certaines analyses. Et cela va nous aider à la prise de décision basée sur les évidences parce qu'à chaque niveau de la pyramide sanitaire, les acteurs auront en fait des tableaux de bord personnalisés qui les aident dans leurs tâches quotidiennes. Donc, actuellement, nous travaillons en fait à la qualité des données, à nous assurer que des 8 outils toutes les données remontent, à nous assurer en fait de la complétude et de la promptitude en travaillant en sorte à ce que les districts, par exemple, puissent faire les sessions de validation de données sur les données issues de l'écosystème digital minimal, ce qui va nous amener à revoir un certain nombre de choses pour qu'ils puissent avoir en fait toutes les informations dont ils ont besoin en fait dans cet entrepôt et l'utiliser quotidiennement. Donc, l'impact que nous recherchons, c'est que de façon systématique, au niveau des districts, on puisse s'appuyer sur l'écosystème digital minimal pour tirer en fait les informations sur la gestion des ressources et l'allocation des ressources au niveau des formations sanitaires. Donc, cela va permettre vraiment de pouvoir savoir quelle formation sanitaire a besoin de ressources et allouer les ressources efficacement pour de meilleurs résultats sur les soins de santé primaires. Donc, voilà ce que je voulais vous présenter brièvement. Je vous remercie.
Great. Thank you, Dr. Dimitri, for another fascinating presentation. And thanks for you for outlining, again, the ambitious integration of a number of digital tools. And also thank you for, I think, the concrete illustrations of how this integrated data should benefit district managers to improve the management of the resources that they're responsible for and help you at the national government monitor how districts are utilising those resources as well. So I think we've had 3 presentations that have showed us, really interesting ongoing reforms that I think in all countries are at early or at pilot stages, with I think in Uganda and Burkina Faso with clear plans for the future rollout in the coming years. But now I want to hand over to the audience for any questions that you have for any of our presenters, and also any experiences of similar reforms or lessons or challenges from any similar reforms that you might be implementing yourselves as well. So please, I open up the floor, and for any of our online participants as well, if you raise your hand or put a question in the chat, we can take questions from you online as well. Thank you.
Thank you very much. My name is Abaka Kurifi. I am the Director of Planning, Research and Statistics with the National Health Insurance Authority in Nigeria. I'm very much interested in these presentations, basically because in my country, we're also in the process of really trying to see how do we deploy that massive end-to-end digital data management system for the health insurance ecosystem. So my question is virtually to every of the presenters. I will really be happy to hear from them. What are those things they did that did not work out well? What are the errors that they unavoidably made? And so that somebody who is about to follow that path will not fall into that pitch. Thank you very much.
Great, thank you. Good challenge. Do we have any other questions? I think we can take a couple and then put them to the panelists. Is there anyone else with a burning question? No. So then, okay. The question is, what mistakes did you make that you would give advice to the gentleman from the Nigerian Health Insurance Agency?
Sorry,
what mistakes did you make that Nigeria can learn from and avoid? So, Animate, Dr. Dimitri, Andrew and Ali, I put that to you. Do any of you want to volunteer to take that?
Sorry, excuse me. Yeah, I didn't hear the questions because I was hung out in the meantime.
Sorry, the question was, what mistakes do you think you made that you would advise? So the question was from the Nigeria Health Insurance Agency, who's saying they're just starting out on their planning for integrating their digital systems. And they said, what mistakes did you make that you would advise them to avoid?
Yeah, thank you so much. I'll start my colleagues, Fahad and will add, but I think in designing the form, we had very detailed information, requirements that facilities were supposed to submit, and they felt it was a burden to them. So they kept on complaining, and I also kept on saying, we need your input to make sure that it is user-friendly. So it's better to have something that is focused and also mapping. We also didn't map out which information is already captured until recently when we started digitizing. That's when he said we could leave some information to other systems. So I think that those are the challenges. I don't want to call it a mistake because I may be held responsible by my colleagues, but I think those are the things that we need to be aware of. Thank you.
Thank you, Ali. Dr. Dimitri, do you want to come in online?
Bon, merci aux participants du Nigeria pour la question. Donc, il faut dire que l'écosystème digital minimal, en fait, est centré dans notre pays sur la politique de gratuité des soins. Donc, on a des cibles qui sont classiques, c'est les femmes enceintes, les enfants de moins de 5 ans et certaines personnes avec certaines pathologies. Donc, avec l'expérience que nous avons fait sur l'écosystème digital minimal, notre Centre national d'assurance maladie universelle a voulu s'inspirer de notre système pour aussi gérer, on va dire, le financement de l'assurance maladie universelle. Donc, ils vont passer par notre système pour pouvoir avoir, en fait, les informations sur les prestations de soins. Et nous avons mis en place un outil automatique qui permet d'analyser les factures et de les classifier en factures valides, invalides et factures à corriger. Donc, les choses qu'on pourrait vraiment améliorer en se basant sur le peu d'expérience qu'on a fait sur l'écosystème digital minimal, c'est surtout en fait la collaboration entre les différents acteurs. Parce que chez nous, si je me répète, on avait au moins 8 outils et les 8 outils sont portés par des acteurs et souvent avec des partenaires techniques et financiers différents. Donc, laisser chacun faire la mise en œuvre de son côté, nous avons appris très tôt que c'était un vrai problème. Donc, il faut arriver à aligner vraiment les parties prenantes, à avoir un schéma d'ensemble et à travailler à ce que ce schéma d'ensemble-là soit vraiment, on va dire, le porteur de l'intervention. Parce que sinon, si on laisse chacun faire dans son côté, il y a beaucoup de probabilités qu'on n'atteigne pas les résultats à temps voulu. Donc, nous avons aussi adopté l'interopérabilité. Donc, il y a toujours ce débat entre interopérabilité et intégration. Donc, à certains moments, nous avons vu qu'il était plus facile peut-être d'intégrer certains outils que de chercher en fait à les faire communiquer parce qu'à la base, ils n'avaient pas été conçus réellement pour communiquer avec d'autres plateformes. Donc, il faut toujours avoir cet équilibre-là entre intégrer des modules dans des plateformes existantes ou bâtir des ponts entre les plateformes existantes. Donc, voilà ce que je peux dire en tout cas par rapport à notre expérience. Merci.
Thank you,
Okay.
Dimitri. Anima, did you want to come in as well?
Yeah, thank you for the very interesting questions. If I get the questions correctly, I think the questions looks like what are the systems that work not well, and what is the mitigation mechanism for the future, or the proposed mitigation mechanism for the future, I think. Just from our experience, just as I have explained in my presentations, We do have different systems, different fragmented systems, which is implemented at different levels, that is the national, regionals, and also zones and woreda levels. With these different systems, just we will have a different data system in data, financial data, and also the service delivery data. Therefore, so in order to have in order to have valid or real-time data, we have to standardize or digitalize the existing system. For example, just we do have a fragmented system. Just we need to have a unified or a single system to have a standard or visible data for decision making. So for in the case of insurance, just for example, just we are doing the financial management systems through all manual basis, including the claim process and the provider and payment process as well. Just so we need to integrate or to digitalize in order to have accurate information for decision makers. This is the point what I can say to improve our financial management system. This is also useful for the Nigerian's perspective as well.
Great, thank you, Animat. Sorry, Andrew, you want to come in?
Yes, from the interoperability perspective, the plan is that maybe in the future we'll have to exchange this data with like Ministry of Finance systems. But also, you also presented that we plan to integrate with other systems like the supply chain and the human resource management information system. But we realize that we are getting more systems, very rapidly developing systems, and yet we did not have the interoperability standards. So in a few months ago, we are able to develop these standards. But again, we realize now we have to work backwards because some systems were not interoperable with others because we did not have these are the interoperability the standards. So as we develop these digital systems, we have now to also review, ensure that maybe we have these standards in place. If they are not, the development of systems should also move along with the development of these standards. Thank you.
Great, Andrew, thanks. Did we have a question online? Okay. Is it Total? Do you want to? Okay, right. So we're going to have a question online. But before that, do we have anyone else in the room?
Thank you. Good morning. My name is Maarten Oranje from Cordate and also as a consultant for the World Health Organization. My question is to Ethiopia. Good morning, Animut. And thanks for a very clear presentation. You also touched upon the exchange of data between the Financial Management Information System and DHS2 in Ethiopia that you're anticipating. So I was wondering, do you have ideas about the types of data that you would be exchanging between the two systems and some of the benefits that you are anticipating from combining service delivery data and financial data? Thank you.
Okay, thank you. Can I respond to the questions?
Yes, please go ahead.
Okay, thank you. Very interesting questions. I go for the first question, that is for data interoperability or integrations. I remember from my presentations for that this time that we aspire to have to happen in the Ethiopian context. Just we do have different systems that we capture the financial data, both financial data and service data. But we have to standardize the different systems into a one digital platform, that is by creating the digital exchange, the data exchange layers by using the adapters, that is the data translators. It translates the existing data to the digital platform, that is the common standards or common language or different systems. So just once we in place this system or this digital standardization systems, we can solve the interoperability. I mean the interoperability of systems, which is not existent there right now. But now once we in place the data integration or standardization, we can solve this problem. That is, systems can be interoperable easily once we in place these data exchange layers. When it comes to the next questions for during the data exchange, what type of data we supposed to integrate or standardize? Just as you are rightly said, just we have integrated or standardized both the service data and also the financial data. The service data just usually we obtained from the DHS and the district health information two systems, and also the procurement as well. And also we from the financial perspective, just we obtained or received from the existing systems, that means the IFMIS, IVEX, and the Zepistry accounting system actually. So both the financial and the service data will integrate through the proposed systems that we are going to or aspire to in place. Thank you.
Great, thank you, Animat. Do we have the online question yet? No, we don't. Any other questions in the room? Maybe I can take liberty of asking one then, which is, this one goes to Animat and Dr. Dimitri, which Andrew in his presentation laid out some of the challenges with trying to bring the data down to the facility level when many facilities don't have IT, don't have internet connections. And Animat, in your presentation, I think when you started with talking about the current system, and you talked about the way that in the Channel 2 resources, that at the moment, again, at the facility level, that's paper-based, and it goes up to the district to be manually then put into the systems. And also this goes to Dr. Dimitri. How are you planning on dealing with the lack of internet connectivity and lack of IT systems at the kind of facility level where this data is generated in your kind of reforms going forward? Is that something you have plans to deal with, or is it going to be a similar kind of workaround like Uganda has, that it will be paper-based and they will have to take it to their kind of nearest office that has internet connection, and it would be entered there? So that would be my question. In your kind of reform plans, how are you planning to deal with this lack of internet connectivity or IT systems at the kind of more rural and remote facilities?
Thank you. Very interesting and very important questions. In order to respond to the questions, actually, as you have rightly said, just we have a limited infrastructure, especially for remote areas. For your information, just digitalization is a priority or the focus area for the ministries. And therefore, just the ministries are what massively worked on the digitalization aspect, including the insurance perspective. Now, just the problem is now existing. There is the internet connectivity and infrastructure problems, as I have said in the remote areas. But the ministry give a priority to digitalize. Actually, just digitalizing all systems is impossible because it's resource intensive. It incurs more resources, but a little, at least for the basic services, it has to be digitalized. Now, just the ministry work towards that, and also just in standardizing the existing system together to have the data visibility and to get real-time data for decision making.
Great, thank you. Dr. Dimitri, I don't know if you're able to come in.
Oui, merci vraiment pour la question. Je pense que le manque d'infrastructures informatiques est vraiment l'un des gros défis, en fait, de nos interventions de santé numérique. Donc, ce qui a été fait au niveau de l'écosystème digital minimal, vu que la fréquence, en fait, de rapportage des données est souvent mensuelle, c'est de favoriser en fait le développement de versions offline des outils que nous avons. Donc, tous les 8 outils pratiquement ont une version qui marche en mode offline et en mode mobile, ce qui permet aux acteurs de travailler quand même sans la connexion Internet. Et en arrière-plan, nous sommes en train de travailler avec les opérateurs de téléphonie mobile pour mettre en place ce que nous appelons l'URL free, qui va permettre en fait de faire monter les données même sans une connexion Internet, voilà, selon les normes. Il faut dire que bien avant ça, nous utilisons aussi pour certaines plateformes le SMS qui permet de faire monter un certain nombre d'informations et que nous récupérons par une passerelle SMS pour charger sur les bases de données. Mais vraiment, la réflexion est en cours aussi pour voir comment raccorder le maximum de formations sanitaires à un réseau national qui, même sans Internet, permet en fait de véhiculer les données. Merci.
Great, thank you, Animat and Dimitri, for those answers. Final ask for any questions from the floor. Okay, we've got 2, so why don't we take both of them, and then we can hear from our presenters, and then we'll go for a coffee break.
Okay. Hi, everyone. My name is Pauli Benzin. I'm a researcher at the London School of Hygiene and Tropical Medicine. And within the school, we are working with the countdown to 2030. That is the consortium of researchers who is tracking progress in reproductive, maternal, newborn, and child health across the world. So we developed an algorithm that tracks donors, financial disbursement of donors across countries, but at national level. And based on the CRS OECD database, and the particularity of this algorithm is to present or to show the financial resources that donors are disbursing through countries by flow, by type of flow, maybe by grants, by loans, but also by purpose. You know, we can track the data by example, by nutrition, HIV. And I think these presentations are very interesting because we are facing this challenge to track the data at the subnational level. And I think this work the countries, the 3 countries are doing is very contribute a good contribution to this challenge is to track the data at subnational level by health facilities, by district level, and it's good. And so I want to know if because the presentation highlighted the data for wages, for stocks, for drugs. I want to know if is the purpose of the resources are taken into account within this ecosystem. And also I want to know if the private, we are talking about public health, but I want to know if private sector is also taken account into this ecosystem. Thank you.
Great, thank you. So a question about in the resource tracking, whether the purpose of the funds is also recorded in any of these systems, and whether the private sector facilities are integrated into any of the data systems. Sorry, and we'll take another question, and then I'll come back to our presenters for that.
Thank you. My name is Martin Natella, and thanks to the presenters for the wonderful work. I work at ID Insight based in Nairobi. I have two quick questions. One is a usability question from the presenters, and Andrew, Uganda, and the rest in Ethiopia. Do you get a sense that the health workers at the subnational devolved levels are empowered enough to acquire and make use of this data for decision making at that level? Or are our systems merely designed to be pushing up data to the national level? So that's my first question. And the second question is really a cost benefit question. If you are a health worker at a devolved district, somewhere, where do you think you'd want to put most of your attention and limited resources to? Is it in building a fantastic digital public infrastructure for health? Or is it in tackling really critical priority health challenges that you're facing every day within your hospital?
Great. Thank you, Martin. Two fantastic questions about whether the health workers and managers at the subnational level are empowered to use these systems for their decision making, and also about the time burden that these systems and the data collection at the facility level imposes on the health workers, knowing that most of these facilities will have maybe one or no administrative staff as well. So two fantastic questions. So I just open this up now to Dimitri or Animat. Do you want to come in on any of the four questions we had from the audience? And then I'll come back to Ali and Andrew in the room. So Dimitri, Animat, do either of you want to come in first?
Okay, thank you. Let me take the first chance to reflect on the questions. Very critical questions are already raised from the audiences. And the first question is the donor disbursement and commitment to the health sector. Just as I have indicated in my presentations, we have conducted annual exercise mapping every year. In this exercise, donors are committed to show their commitment to support the health sectors, their commitment with specific thematic areas, in which areas they are committed to support for the coming fiscal years. Based on that, we receive the commitment of donors or development partners based on the resource mapping templates. The templates indicates what even the areas, the thematic areas, and also the geographic areas also. Which geographic areas that partners want to support or want to work on that. Based on this, we have already the resources commitments, the disbursements at hand. Even in the same fashion, the subnational levels also managed in this way. That there will be challenges. There are limited informations. As I have told you in the presentations. Regarding the private sectors, as you know, the private sector is next to the government. It takes the lion's share of the health contributors. But in the resource mapping, we didn't include during the resource mapping exercises. But we separate working procedures. We manage the private sectors. In order to enable them to work or engage in the health sectors as well, by creating conducive environment for their engagement, like the working procedures, just smoothing the working procedures, and also easing the bureaucracies, the government bureaucracies to work on the health sectors. In the health workers data capturing mechanism, for the Ethiopia, the information revolution is the priority or the focus area from our strategic plans. And now we assumed or we believe that even the health workers or the health facilities at down to the regions It's not only what collecting or gathering information and to send to the national level. Even we need to use the generated data at the facility level for decision making, for their planning, for their service improvement, and the like. And not only for the purpose of just collecting data and send it to the national levels. This is the current practices. And the other one, when we get the resources, be it the treasury or the government or the donor resources, do you use for building or construction of fancy buildings, or you're allocating for the thematic? It's automatic. The response is automatic. Just, I mean, resources are limited. With this limited resources, even we are prioritizing to allocate resources. Which area can bring more outcome if we support? Which area we are working or engaged to have more outcomes or impact. So just we invest impactful areas or the programs. So just we allocate for the priority areas for the health sectors, especially for as indicated in my slide and presentations. Majority of the resources or the lion's share of the resources are directed to the primary healthcare level, because the majority of the services are what provided to the primary levels, and also majority of the community or the population is located in the primary levels. That's why we focus on the priorities at the primary healthcare levels. Thank you.
Thank you, Animat. Dr. Dimitri, did you want to come in?
Oui, merci pour les questions qui sont vraiment intéressantes. Donc, il y a deux aspects peut-être sur lesquels je pourrais revenir. Donc, dans notre initiative, le secteur privé est bien pris en compte parce que la politique de la gratuité des soins s'étendait à certaines structures privées conventionnées. Donc, ils sont concernés par notre initiative. Et dans le cadre de l'assurance maladie universelle, ça va être aussi adressé aussi bien au public qu'au privé. Donc, ça, c'est le premier point. Le deuxième point par rapport à tout ce qui concerne peut-être la charge de travail au niveau du personnel de santé qui est censé rentrer les informations. Donc, nous avons mené la réflexion et nous travaillons de telle sorte que ce soit en fait pas fastidieux à moyen et long terme. Pour le début, c'est forcément fastidieux parce qu'il y a des données historiques à saisir. Mais après, on va peut-être, au niveau de chaque point de prestation, avoir certaines informations seulement à saisir au fil de l'eau. Donc, cela va vraiment amoindrir la charge de travail et il n'y aura pas vraiment... C'est des choses qu'ils faisaient en fait d'habitude, sauf que ça va être plus systématique et ils vont pouvoir aussi capitaliser les données parce que les tableaux de bord sont faits pour tous les niveaux de la pyramide sanitaire. Merci.
Thank you, Dr. Dimitri.
Thank you so much. Three questions. Colleagues have answered some of them. But in terms of use, I think we are coming from a point of view that if you are in charge of a facility, you are a manager, and therefore you need information. And you cannot have this information somewhere, so you need to own it. So first thing is that we build their capacity for them to understand that this information is for them to use. They send it to the national level to ensure that it is, we do quality assurance and tell them this is okay, because when you're planning, you follow the national planning framework. So you have priorities coming from up, so margin from the ones at the district. But also do this by capacity building. It's continuous capacity building. So making sure that they use the information. We have sessions, I think, tomorrow that also are going to demonstrate so far. How do we link what we are doing with PFM? Do these people sit down and they review the information? They understand what they plan to do and they link them to results. So they are able to we are doing pilots to make sure that it is carried up across the country, but one, to make sure that they are managed and they should be in charge. You can't be in charge of a health facility. Money is coming direct from the central level to your account, and you don't have time for that. That also addresses the issue of whether they should focus on treatment, information. So we are saying you need both, because you need money at the same time, you need results, but also you need to show that you are efficient. And so things are changing, and we are looking at making a manager is all around, but also trying. Uganda has just reviewed the structure, staffing norms, so we have been able to cater for any needs that are required so that these people are not overburdened. Lastly, at every level, we're able to capture resources. The last table, we encourage facilities to capture all sources of funding from public and private, including if you have a company and it's within your facility and they're able to fix something, put it in the work plan. If Gavi is giving you money, put it there and then allocate, say, for community interventions, $1 will come from government of Uganda, $2 from Gavi, 3 from Global Fund. In the past, that didn't happen, but right now, if you look at the work plan, they're able to do it. So you use it as planning, but also mapping resources, but also a resource mobilization tool. Thank you so much.
Yes, maybe to add on, yesterday we had the discussions here on human resource availability, and yes, we realize yes, you are able to map and know where the gaps are in terms of human resource, or even the gaps in the supply chain. Specifically lack of drugs in health facilities, and maybe lack of human resource in health facilities. But when you have also this extra information on availability of wage, money, funds coming from the central government, but also other external sources, then it becomes easier for us to hold accountable across all levels, while you have these resources, and yet you are not able to recruit in time, so that we avoid the inefficiencies of having us send back money to the treasury because we are not able to utilize the money within the financial year. Thank you.
Great, thank you very much. That closes the first part. Can we once again express our appreciation for our speakers, for Animat and Dimitri online from Ethiopia and Burkina Faso, and for Ali and Andrew from Uganda. Thank you very much.
Thank you.
If we take a 15-minute break now, we'll be back for part 2 to hear from Ghana. So if we can try and be back in the room at 11:05, and we'll start promptly at 11:05. Thank you. Which is not based on the kind of digital system reforms, but is about bringing together the data sets that are generated through different systems to improve the analysis that can be done to improve policy. So, Dr. Hamza, thank you very much for being with us, and over to you.
All right, so thank you, Tom. I'm sure the break we've taken is having some marginal productivity on us, so I'll try to be quick. So this is a study we are doing in Ghana Health Service, trying to leverage data to kind of help us understand how the distribution of health workforce affects productivity and ultimately health outcomes in the country. Next, please. So it's a study we started in 2014. And then what we tried to do was to look at the productivity and allocation of personnel across Ghana's largest healthcare delivery agency, which is the Ghana Health Service. And then we use data sets covering health workers numbering over 100,000. And then we had facilities numbering over 9,000. The facilities, just as we saw in the case of Ethiopia earlier in the morning, we have from the community up to the district, up to the secondary and then tertiary level. But for the purposes of this study, we terminated at the secondary level. So what did we seek to find? One, we sought to estimate the marginal productivities of the different cadres of healthcare workers we have in the country. And also we tried to measure how changes in the staffing levels affected service delivery and the quality of care at those service delivery points. And then ultimately we tried to estimate the impact of the allocation of personnel and financial resources on health outcomes. From the study focus and objectives, can we go to the next slide? It's obvious that we needed to triangulate data from different sources, and then why we sought to do that was, one, you all will agree with me that the nature of healthcare delivery across the world is multifactorial. It involves other multi-factors. Also, as we've seen in other country experiences now, we have issues of data silos. So data sets on health workforce is different from health financing, also on logistics and all that. So there was the need for us to look at the issue of the data silos and possibly think about how to operate those silo data. And then ultimately is the fact that integration, we all know, has enhanced benefits. If all these data silos and systems could speak to each other, we'll be able to have a more comprehensive analysis of healthcare efficiency and effectiveness. Now, so from which sources and how did we do the data integration? So for the sources in terms of the health financing, the financial resources, most of our, if you follow the healthcare delivery landscape in Ghana, national health insurance coverage averages over 80%, but we still have some out-of-pocket payments now. And then those facilities or service delivery points internally generate revenues. But for the health financing that goes through the national health insurance scheme, we have a data system known as the NHIS Claimit, and then that captures the financial resources. Now, when it comes to service delivery, as we saw in other African countries now, we have the DIMS tool that captures the health service outputs. And then when we come to the personnel now, that it was subdivided into two, where we have the HRMIs that looks at the payroll, and then the HRIMs that looks at the nominal role. So both the HRIMs and then the HRMIs, they provide labor and compensation input data. For the integration processes, having to extract from all these things, so we extracted data by cleaning and trying to reconcile across these different data sets now. Once we had cleaned and reconciled the data, we tried to transform the data, that is to match the facility level financials as against the staffing and then the service delivery records. And then once we had extracted, transformed, the next we did was to load, where we handled some missing data and then inconsistencies we found. Next, please. Obviously, integrating data across these platforms would come with challenges now. So as we saw in the Ethiopian and then the Ugandan issues now, there will be issues of data inconsistencies. Also challenges with data merging, data silos, and even different data governance structures now as to who has access to which data set, and then do they even talk to each other, and then ultimately we would have data gaps now. How did we address these challenges now? So for the differences in the reporting frequencies, which the inconsistencies, we tried to standardize the reporting formats. And then where we had the data gaps, so in most of the instances, we had either focus group discussion or key informant interviews with the data processors and controllers just to get understanding on the data sets. And then through that, we were able to foster data literacy and collaboration across departments now. So you have the DIMS2 guys that are only focusing on service or output data. You have health workforce just looking at distribution and all that. When we had the key informant interviews or the focus group discussions, we brought all these data processes together for them to understand that what you had impacted on the other, and then the need for interoperability or integration now. So what were the key findings of the study? What we realized was that as the number of staff or personnel increases now, and then you saw that outpatient visits and maternal health increases until a point where we began to have the diminishing marginal returns or productivity now. Where you would ask is at what point? So the study was interesting. For those of us who've done staffing norms in our countries, especially using the wheezing approach by the World Health Organization now, we saw that marginal productivity began to decline where we hit the maximum ceiling of the staffing norms, where you begin to have too many staff crowding out and then virtually not having anything to do now. Now, what are the implications of these findings now for policy? Next slide, please. One, in the course of the study, we identified that we had areas that were overly staffed and also areas that were understaffed now, which called for issues of redistribution of these findings now. We also found out that linking financial inputs, with health outcomes allowed managers to see the need to make cases for justification for improvement in the health service, or even in most cases for asking for more resources. And then for improved service delivery, the data gave us the evidence that once we were able now to talk to each other, service delivery, finance, health workforce, we were able now to improve service delivery, outpatient and preventive care services, all increases now. For the implementation status, you would see the first policy implication, which is the more efficient labor allocation, calls for the redistribution of staff now. But this comes at a cost because per existing labor laws in Ghana, if it is the employer that is moving the employee, the employer should be willing to pay the cost associated with the movement now. And then that brings into question the issue of labor, turbulence on that front, and then whether government has what it takes now to really bear the cost of having to redistribute. But be that as it may, this informed or created a policy dialogue that we didn't need to, as it were, request for financial clearance to wholly recruit new employees into the sector. We could make efficiency gains just by redistributing in areas where we were overly staffed, and then also trying to, as it were, beef up areas where we were understaffed. Next slide, please. So what are the key takeaways from this study? Integrating data sets across service, human resource, and then finances now. For us, it's crucial for evidence-based policy. This has got health workforce policy actors in Ghana talking that, yes, the time now to integrate data across these spheres is now. And then the findings so far also highlight opportunities for optimizing workforce allocation and funding. And then for future research and policy discussions, you could focus on practical implementation challenges now, because we also realized that productivity of the workers also varied according to their geographical location now. So it wasn't a one-size-fits-all. All right, so thank you. Basically, that's about the study.
Thank you very much. Before you finish, can I just ask you, I know can I ask you about the publication plans for the study? Because I know you have a working paper under preparation. So I just wanted you to have a chance to tell the audience where they might be able to see these findings kind of in print in the official version in the future.
Yes, so I think myself and the co-authors, we are working towards publishing it in the Health Policy and Planning Journal now. We are in the peer review process now. We've submitted, we've got a few of reviewer comments, which we are trying to address now.
So watch out for that paper forthcoming in the HPP journal. I'm going to ask Maritz now to come and present on the potential for her other technology solutions for supporting health financing with a focus on Eastern and Southern Africa. After Maritz has spoken, I'm going to give the first chance to speak to Martin Atella from ID Insight, who has been leading some work in Kenya on looking at the challenges for joining up the financial and non-financial performance data. But first, over to you, Maritz.
Thanks so much, Tom, and great to be here again. Do we have my slides? Thanks. This is a fantastic session, I have to say. It's really encouraging to see how the data work connects with the digital work with and trying to make the leap to outputs and outcomes. And sometimes we're very much inward looking with our work. So we have tried to map out specifically some challenges that are encountered with our health financing work, and relate to them, right? One problem at a time, the type of technology solutions that could potentially be drawn upon, right? And when we were looking through some of these implementation challenges, that these were the ones that were kind of that we tried to map out first. So these sound like just being put out there. They sound quite abstract, right? But thinking through what we're trying to do, right? When we talk about health financing, specifically purchasing and engaging on the primary care space, right? One question is, who are the people that are seeking care, right? And how do you record what service is actually being delivered, right? One needs to have some basis for that to inform any purchasing decisions, right? So, and that relates to the first, right? How do you record, and how do you make sure what you record actually reflects what happened at the facility level, right? Then the second question, right, is around the data quality and the integrity. How do we know that the data quality is appropriate and that there is integrity? Because there is, right? Let's face it, there are incentives to over-report if payment to these facilities relate directly to the type of information they receive, right? So one needs to keep that in mind. Then the third is making the actual payments, right? So often we relate to this question of, like, we try and talk about how do we get money directly to facilities, and this conversation has been happening in all shapes and forms, and it's happening in a lot of countries, and still we're grappling with this, right? How do you actually make a payment to a facility that may be remote, that may have challenges with accessing financial services, that may not have bank accounts and so forth, right? So what are the technology solutions to deal with this? And then lastly, kind of the questions around accountability and transparency. So even if you do make that payment, how do you make sure that there is transparency in the process? And how can you then work on making evidence-based decisions? So can we, next slide, please? Okay, so there's a lot going on in this slide, so I realize that. But there are just a couple of points that I'd like to show. And so first, there's, if you look upwards, right, you see the patient, the purchasing agency, and the service provider, and they all play a different role in this flow chart. And right, the reason why we've mapped it out in this way is to understand, what are the different points of entry that will have to happen. What is the challenge related to those, the challenges that I just talked about a minute ago? And then where are the potential digital technology solutions that could apply? And so one thing that we point out here, right in the beginning is who is the patient, right? As a person walks through the door, how does this person get registered? Right? Is there an identity management system in place? And then there's the whole patient administration question and so on. And then once that person is registered and the patient receives the service, and how do we know what service was actually delivered, right? How do you have confidence that whatever service was delivered is actually being recorded as such and feeds into a data management platform? Right, so then that's the next step, right? So they receive a service, which is what you'll see here, and that then needs to be recorded. And so if you kind of follow along in the chart, and then we say, okay, something's been recorded, and that needs to be confirmed. And then once that's been confirmed, and you have a database, then that can then inform the budget allocation process. Right, and that's basically the last box all the way in the top, right? So how do you make the payment? Okay, and on what basis? So really just 4 main steps. Can you move on to the next slide? Okay, so the first challenge that I want to go into here and then point to some examples is the identity management question. Right? So in some countries there is a registry, right? And in others there may not be, but in any case, one way or another, right, there needs to be clarity on who this person is that walks through the door, right? And that's the first point. So you need to have this ID connector. Can we move onto the next slide? And so then we're saying, okay, if this is a challenge, what are the opportunities? What is it that one can do to start on the data recording process? And so we've all been through a process where one way or another, there's fingerprint technology, right, where you have fingerprint recognition, which is something that's becoming increasingly available, right? And a lot of people have that on their phones. There's facial recognition. There are other things such as iris scanning or voice recognition. So there are a lot of things available at very low cost that help with the registration process. And so and that then helps, okay, figure out, okay, who's this person that's walked through the door, and then how do you relate as a first point of entry for the database, and then the next step is what service was actually provided. Right? So on this technologies, one of the things that we'd like to point out to is the experience in Kenya with the introduction of biometric fingerprints. And right, a lot of you are probably familiar with this. There's been a lot written up, both on the good side and on the challenges associated with it. But really, right, the idea was to verify beneficiaries at point of service, right, to reduce fraud. And then support the whole thing would then support the claims processing question, right? And that should reduce fraud, improve identification, and eventually enhance accountability. So, right, so there, what we're trying to say here is that the technology aspects are there, right? Available at low cost. There is experience with doing this, so it's something that can, lessons that can be drawn for a lot of countries here, right? And I think particularly interesting once one looks at the implementation experience in Kenya is that it's a bumpy road, but there is a clear direction in the process. We go on to the next slide. Okay, so then you move on and say, okay, well, the patient, the service has been recorded. How has it been recorded? Where has it been recorded? How do you make sure that there is integrity in this process? And there, blockchain can potentially play a role. So if we move on to the next slide, you see, blockchain's been, is often associated with cryptocurrencies and so on, but that's really, a byproduct. It doesn't necessarily have to be associated with what you do. But the question around blockchain is more about where, right? Where is the data being stored, and how do you make sure that the data can't be tampered with, right? So that you have confidence that what's being recorded and what's being done also relates to with what you're producing, right? And then, right, the question relating to us in the health financing space is, how can we potentially apply the technology? Right? What does it cost? What does it take? And what are the capacities needed to do that? And within the health space, there's relatively little, right, to draw on. But within other sectors, there's more. So there's been experience. If we move on to the next slide, in the education sector in Ethiopia, for example, where there was an attempt to store education attainment recording on a blockchain, right? So that you have credible data on the performance, right? So that you know, right, who's received what, right? And there's there's credibility in this process, right? So that eventually it enables students to have verifiable records, and institutions to be able to draw upon those, and that then improves trust. And in the same way, right, when we think about our health financing situation, that's what we want, right? We want trust that the type of data that's being produced is accurate and can then inform purchasing decisions. Next slide, please. Okay, then the next step, right? How do we actually verify? Right? So you create data, you want to store it on the blockchain. How do you verify that that there actually has been a patient, right? And that the provider who said, we produced a service actually has produced this service, and there's been a link with the patient. Next slide. Right, and there is mobile. There are mobile verification systems where you get, for example, a text message being sent out, and you have to say yes or no whether you received the service. If you didn't, if you say no, then there will be a prompt, or it can trigger an audit. If you say yes, you can respond to those sorts of questions, and that all relates to the flow chart that we're showing earlier. And by the way, not only SMS based, it can also be through all sorts of other issues, right? So, I mean, many of us have been exposed to these one-time passwords that get sent. You forget your password, you have to figure out what to do, and so forth, right? But the point is really that the technology is available. It's available at low cost, and it can serve a very specific purpose for our health financing needs. Next slide. Yeah, perhaps in the interest of time, I won't go into the experience here of mobile verification in Nigeria, but just to point out, there is a lot of experience, right, on how to do this, and that's kind of triggered very specific reform actions in the health financing space that relate to accountability and the transparency trail. Then lastly, the last point that I just want to point out here relates to the actual payment, right? And I've alluded to this in the beginning, right? So this is the last box where, next slide, please, right? Where you can say, okay, mobile money has really become widely available, right? We're all familiar to this. In the private sector, if you want to buy something on the market, you can easily pay for stuff with your phone, right? We also use mobile payments for conditional cash transfers very often, right? But somehow the mobile money conversation, or the fintech conversation, is by and large lost in our health financing dialogue. Right? So, we still talk about it's difficult to get financial services to health providers, yet most people have a phone, right? Most people have and use this phone to conduct transactions, right? But we can't, for some reason, have mobile wallets, right, and populate those mobile wallets at the clinic level. And it's really, I think, kind of a frontier space where a lot of work can be done. But one doesn't necessarily need to have a bank account or access to a bank account in order to receive money and to utilize that money. So some of the benefits of potentially using these phones is one, reach, right? So you can be in a remote place and have access to mobile money. Another is the stewardship function, right? So government can have stewardship in terms of knowing where, what kind of balance has been pushed. So you have a full understanding of what's where. Then there's efficiency in cash management, because you'll know, right? You'll have one wallet and then sub accounts that relate to that wallet, where you know what's the total balance, and that can be integrated into a treasury single account, right? And from that perspective, it will strengthen cash management and oversight by the central government. And there's, of course, transparency and accountability, right? So you spend money, and you can spend money, say, to registered suppliers, then you'll know, right, who spent that money, and you'll know what you received for it. And if you look at your own credit card statements, for example, you go online, you'll see, like, did you spend money on food and beverages, right? Or did you go and buy coffee, or whatever it is, right? It'll give you an overview. Right? And in the same vein, you can do that for fintech transactions. And so there is a lot of transparency and accountability, and requires less capacity to do that, right? Because you don't necessarily need to keep paper-based books if this is done on the back end of a digital provider. And then there's, of course, questions around efficiency and financial inclusion, but we don't need to go into those. If we go on to, so I won't go through these. You're all familiar with kind of the extent to which mobile phone has really revolutionized the financing sector across the continent. Move over to, I'll skip the AI and machine learning question, because in the interest of time, just to, next slide. Just to say, no, the one before. Just to say as a quick overview and recap, right, of what I talked about. There's the identity management question. Technology solutions have matured, are available at low cost, right? Then mobile phones can be used to verify, right? Being used at low cost and being applied in the health financing space specifically. A blockchain sounds complex and difficult and fancy, and people talk about it using up a lot of electricity, and being applied in some spaces, and be interesting to explore further where what is really relevant and what problems it can solve for us. And then there's the fintech question: mobile money available, widely available, and not necessarily difficult to help address some of the needs that we have, right? So there is a lot of potential there. And lastly, what I didn't talk about is the artificial intelligence and machine learning questions that can really help with data analysis and relating this further to the decision-making space, right? So you create a lot of data, you have confidence in the data, you know what services were being produced, then you can apply some of these tools to reflect back on what's been happening, and how performance should relate to budget allocations going forward. So can we move on to the last slide, please? So in the end, right, it's important that we contextualize technology always, right? So technology is not, right, technology is always only going to be technology, and it should only ever serve a very specific need. And so the challenge is going to be identifying the need, right? There's always the functional question that has to come first, and then see whether there are some technology solutions that can help us with what we're trying to do, right? But we shouldn't be letting the tail wag the dog, so to speak. Last slide. Right. So technology solutions can potentially offer a way to address long-standing health financing challenges. Right? I think there's some recognition of that, and they have become increasingly accessible, and they've become increasingly affordable. Right? So I think there is space for us to look at some of these things, especially with regards to the challenges that we've laid out. Right? So then. The third point that I want to point to is that there is experience from other sectors, and just because, say we haven't used blockchain in a specific country on a specific health financing need, doesn't necessarily mean that it's not worth considering, right? So if you look outside the health space, perhaps there are good lessons to be drawn, right? And then lastly, of course, there's context and there's political economy, and it's always more difficult than you can pack into 10 slides. But I think a lot there for us to think through, but to consider. And I'd like to just advertise a short report that we've produced a little while ago that goes through these things in an iterative way, and that's available on the web. But we'll share the presentation and the link to the report that goes into details on these things. Thanks again, Tom and team, for inviting us, and yeah, great to be here.
Thanks, Moritz. That was a fascinating, rapid run through of some of the other kind of technology solutions we have. And I think your very important points about, contextualizing them to make sure that they are being introduced, focus on specific causes, not that we're just using a hammer because we have a hammer, and that we're making sure that we have a nail that we are going to bang in, and the importance of piloting them to before rollout. We're going to move on to Q&A from these presentations now, from Hamza's presentation on the analysis they've done utilizing those different data sources in Ghana, and Moritz's. But first, I'm going to ask Martin Atella from ID Insight in Kenya to say a few words about the work that they've been doing. So Martin, over to you.
Yeah, so good morning. Oh, is it afternoon already? Yeah, my laptop still reflects the time in Kenya, which is afternoon. My name is Martin Atella, and I work for ID Insight, a global data and evidence organization based from Nairobi, Kenya. I've been asked to speak very briefly about a small piece of work that we did in Kenya with the support from the Gates Foundation to sort of try to understand the flow of health, financial, and non-financial data, and how that helps to support accountability processes, particularly performance accountability processes in Kenya. So what I'm going to do is just to briefly speak about that work, and then tell you a little bit about how that work has led to a different conversation with the National Treasury within the broader portfolio of public finance management work that we are doing, and the kind of hypotheses that we're trying to test with the reforms that we are working with to support government with. So as you probably might appreciate, Kenya, like many other African countries, face a challenge in trying to translate financial investments into improvement in health outcomes. And when we looked at the systems in Kenya, we realized that one of the key challenges that inhibits the connection between financial and non-financial data is really a lack of definitive framework that guides that process. So there's really lots of standard guidelines that guide how financial reporting is done on the one hand, and lots of good practice around how non-financial reporting is done, particularly at the sector level. But really nothing that helps to connect those two sets of data. And the implication of that is that oftentimes you have decision makers who really can't tell whether they're sending money to the right things, or whether the investments they're doing with the money in the health sector is actually bringing them the kind of returns they're aiming for. I'd like to give one example, which is controversial, so you'll bear with me, and that's the maternal mortality rate for Kenya. If you look at the data for the 2018, 2019, all the way to 2020, 2021, maternal mortality rates have fairly stagnated at around 355, 362. Again, this data can be controversial. What government considers is the right data, and what other external actors like the WHO, World Bank see as correct data can be contested. But I use that example to illustrate why it's important to think about these two sets of data. Because if you look at the investments that Kenya has done in trying to reduce maternal mortality, it's really been significant, including some of what I see as vertical programs, like in the previous regime, we had a Linda Mama program, which was tied to a national health insurance scheme. So can we really tell that those investments are giving us the kind of returns we want to see as a country? The other point I want to raise about this is, there are two main systems that helps the health systems to capture data, the public finance and the health system to capture data. On the public finance point is the integrated financial management system, which is common across many countries. And from the health system side is the Kenya Health Information System. When we delved into these two systems, let me hold IFMIS aside for now, we realized there's really limited communication between those two systems. There's really no very limited opportunity for staff at the National Treasury to integrate IFMIS with the information that is being collected in the Kenya Health Information System, KHIS. Right? So that sort of also leaves them blind. What is it that is going on in the health sector? And I'll come back to that point a little bit later. Let me run you through some of the few challenges that we identified with this work. So one is generally that system-based inefficiencies. I think Tom talked about this, a siloedness in which you have numerous systems, including some which support specific disease areas like TB, like HIV. And those systems are fairly collect data which is siloed and therefore leaves the government blindsided in terms of how resources are being used or whether those resources are producing desired results. A subsequent consequence to this is that, if you're sitting in National Treasury and wondering, should I then add the Ministry of Health additional money this financial year? How do I do that? Do they have the right data set for me to make that decision? And how do they justify the performance that they're producing? Linked to the question I asked earlier, when we spoke to a number of key actors in the health sector, lots of health personnel expressed frustration around the huge demand that is placed on them to collect data, to process that data, and then to use that data for decision making, while on the other hand, supporting service delivery. So, we tend to think about systems in a very blinded way. We just think, okay, when we conduct trainings and we support health workers, they will be able to then collect the data, run it, analyze it, and also decide which of this data they want to use for decision making. The situation on the ground, I think, is much more complicated than that, and also very context-driven. In other parts of Kenya, a health worker has no opportunity to think about anything else apart from the queue that he has to deal with. In other parts of Kenya, maybe there is that opportunity to look at the data and engage with it in a more useful way. The other point that links to health workers is really incentives. We don't seem to have enough incentives. We don't seem to have enough incentives to really help health workers invest really in engaging with data. And those incentives could be those that encourage them, some forms of rewards that encourage them to do this, or some form of sanctions, right? Linking to the discussion yesterday around accountability. I want to move on quickly, because I have only 2 minutes, to bring about the point around performance accountability. In the case of Kenya, we realized that there's so many actors who are charged with the responsibility of ensuring accountability. Because when we talk about linking financial and non-financial data, we're talking about looking for results, right? In the PBB language, you talk about budgeting for results. In the case of Kenya, Parliament plays an important role in the budget process. And one of the key challenges that we picked up is the ability of National Assembly members to actually move and cut budgets and insert new items that were not originated by MDAs. In a good system for budgeting and resource allocation, you would expect that budgets originate from the ministries, the departments and agencies upwards, and then Parliament plays an oversight role. In the case of Kenya, Parliament is able to move lines and insert their own preferred projects for implementation. And once that has happened, there's no opportunity for National Treasury to say, no, we will remove this from the budget. It has to be funded. Now, The work that we did in analyzing financial and non-financial data in the health sector led to a new conversation, which is sort of linked to what National Treasury is currently doing to address the challenge of using data for budget process. And one is that the National Treasury is trying to revise the standard charts of accounts and also to move from the practice of cash-based accounting system to accrual and zero-based budgeting, in which every MDA is expected to provide justification for requests when they make them. We're trying to test 4 main hypotheses, and Tom, if you allow me to run through them, because I'd love to hear what you think about this. As well. One is that when we are able to provide a unified and integrated data management system that combines financial and non-financial data, the integration will allow for policymakers to allocate resources in a much more cost-effective manner. So we want to try and see whether this is possible, working with the Ministry of Health and Ministry of Education in Kenya. The second hypothesis we are trying to see is whether providing a complete and consistent integrated non-financial and financial health indicators will facilitate the creation of trends that assess health outcomes. So can we be able to just move from reporting to really be able to look at trends that come from the health sector, and whether that leads to better service delivery for citizens? And the third point we're trying to look at is whether aligning budgets with outcomes really can help incentivize the health system to do better. Right? If I'm a medical officer in a devolved unit, do I get to be punished because I'm doing better for allocating resources better? Or are there incentives? Is there a way of aligning those incentives to be much more efficient? And finally, we're trying to see whether an integrated health and financial information system would empower oversight bodies in charge of accountability to do their work better. I have in mind the Auditor General, I have in mind the controller of budget, so that their reporting moves from just allocation and spend to allocation, spend, and performance. Tom.
Great, Martin. Thank you very much for outlining the work in Kenya, some of the challenges you found, and I think very useful to so explicitly set out what you're hoping to see from those. So thank you. We're running a bit behind time, so I'm just going to go straight into Q&A. I'm going to ask you to be quick. If there's no questions raised, we will go on to the next section. But is there anybody who would like to raise a question to any of the speakers?
Yeah, thanks so much for all the speakers. My name is Olivier Onvlee from KIT, the Royal Tropical Institute in Amsterdam. And I have a question for Hamza, but potentially also for the other speakers. Thanks so much for the presentation. Really interesting to see this. Really looking forward to the publication upcoming. I wanted to ask you, but maybe also the other presenters. We've been talking about silos. We've been talking about bringing data sets from these silos together. I'm also really interested to understand a little bit more from that next step, bringing perhaps some of these stakeholders that have also been working in silos together, and some of the lessons learned from that process of trying to go into those implementation discussions. How did you convince them to work together? How did you balance their interests from the different thematic groups? And here I'm also particularly talking about different ministries, of course, on the horizontal level, but also presumably in Ghana, how do you involve the regional level in these decisions, and how do you encourage them to contribute? So thank you.
Great, thank you. I can see we've got another question over there, Pakwanja.
Thank you very much for all the presentations. My question is regarding the presentation on the payment mechanisms and the technologies that are there. I think more of a practical question. And I know part of the presentation will say that these technologies are becoming more affordable, but I just wonder what are the cost implications? Are we talking of open source softwares here, or the hosting? Is it free? What are the costs associated? And I thought it was very interesting also to hear how Kenya is doing it with the fingerprinting, and I just wonder about the costs of that. And I imagine to roll it out countrywide would be a huge cost. But I just wonder if we have any Kenyans that can speak to this and just like trying to learn, because I realize, I think the way it's been presented seems like a very good solution in terms of validating the information that is coming from the facilities and ensuring that it's there's less fraud. But I wonder what trade-off there is in terms of cost to having these technologies available.
Great. We'll see if we can make it a set of 3 questions. Is there anybody else who wants to come in?
My name is Silas from Rwanda. Thank you for the presenter. My question is, it's about the one who presented about using technologies. So how do you ensure the privacy of the clients, of the patient, when you are using digital tools and that's required to correct individual information, identification of patients and the diagnostic? How do you ensure the privacy of those corrected information? Thank you.
Great, thank you. So we've got a question for Hamza on overcoming silos and involving the regions, and then 2 questions for Moritz on the cost of some of the technology solutions, particularly on the fingerprinting in Kenya, and whether we have any other Kenyan delegates here who would like to answer that, and also on the privacy concerns. So I'll hand over, Danielle's coming with a mic for Hamza first, and then we'll go to Moritz.
All right, so thank you. Bringing the stakeholders together. First was advocacy. One is one healthcare delivery agency. We just happen to be working in silos, but we have one outcome, that is to improve the health outcome of the average Ghanaian now. For those at the regional, what we do is try to automate and then make them web-based now. So data entry both at the facility through the district to the regional and even national, where I am now, is accessible to everybody. And then like I indicated earlier on, we brought those stakeholders to some focus group discussions where we discuss and try to lay bare the benefits of us working together, not in silos, to improve data collection and utilization. I don't know.
Thanks so much for these excellent questions. We did actually, when we initiated the work, map out, what's the cost range for specific interventions. But then eventually this became so context specific that we dropped that table from the final report. So I don't have the access to how much the cost in Kenya to deploy that, but generally speaking, there are these handheld devices for fingerprint technologies that are relatively low cost, right? And then that can be applied and deployed at the clinic level, for example. Yeah, the other option is, of course, that you use your phone, but then you have different phones that have different types of applications, and it can get messy. On Silas, good to see you again. Yeah, really good question, and it's very tempting, of course, to think about that integration of medical records, for example, into such a system, because you start generating a database, and ideally you'd want the physician to have access to the medical records, but these privacy concerns are really dominant, right? So, and there's always this tension between what is it that you put into the database and how can you ensure privacy. And there are some options and solutions in the digital space that can give reasonable assurance on privacy. I mean, with blockchain technology, for example, there are specific keys that then only the user can access and can extend to the physician that the user sees to provide access to their specific data. But yeah, so it's always really a question of to what extent can privacy really be guaranteed, because that should be that is a paramount concern to everybody. So I really appreciate that question. Well, thanks.
I don't think I have an answer to the cost question, but I have a reflection that I didn't share, and I hope I'm allowed to be controversial here. Kenya has put in place, I think they're putting in place what they call a digital health superhighway, anchored in legal legislation. And I think the point I want to reflect about is often you realize that governments will prefer to set up an entirely new system, even when there was already some system that could be improved. And I'd love to hear from the government people who are in this meeting why this is often the case. And for me, these are the political economy discussions that we face as a challenge with regards to the overemphasis on utility of systems to sort out problems vis-a-vis the reality on the ground that the politics, the interest, and everything that surrounds this may not be driving us to finding a solution, right? It may just be another cost of something else that we are putting up. We're all excited about the digital superhighway that is being put up in Kenya, and we look forward to see how that will help deal with the siloedness of data and whether that would drive towards more efficiency. But its cost is huge. I mean, you could just go online and check. It's a huge conversation Kenyans are having. Do we need to invest close to what, $1 billion in health information system, right? So I said I don't have an answer to you, but just for us to really think together, and perhaps government people are here to help us reflect. Do we need to be thinking more politically when we are suggesting these new systems? Maybe.
Thank you for those reflections on the cost issue, Martin. So we'll do one more round of questions, and then we'll go to closing remarks. So do we have any further questions? No, then maybe we can skip that and go straight to the closing remarks. So I'd like to invite up Danielle, Owen, and Marie-Jean. I think we can come and sit at the front just for the closing remarks. Great. So I first want to express my thanks to Owen and Marie-Jean for supporting the organisation of this session. And we're gonna hear short closing remarks from each of you before we finish and we let everybody go to their lunch. So Owen, first over to you.
Thanks, Tom. And you didn't make any of the other speakers get up on stage. I'm surprised, but no, this is good. And good afternoon, everybody. It's officially afternoon in Rwanda now, so we'll start with that. I've just a few quick reflections on the session today. I think it's been a really rich conversation this morning. And I think across the presentations, I thought it was really valuable that all of the country presentations started with a use case. I think some of the questions around digital systems and technology in the past have been driven more by the technology than by what governments need now. And so I think looking at the issues of absorption in Ethiopia, tracking services and linking them to financing data in both Uganda and Burkina, and basically looking at health workforce, one of the biggest drivers of cost, and how it can be made more efficient. I think these areas just highlight how relevant the questions are. And I mean, I'm a little surprised that I think I'll be the first person to mention the kind of crisis mode that a lot of the countries we're working with are tackling at the moment with this USG freeze and everything associated with it. Maybe that's because the news changes every day and it changed again yesterday. So, but I think we should, confront that and say, these use cases that we've talked about today are so salient. They're like the most important pressures facing ministries of health and finance at the moment. Efficiency, increasing absorption to grow the pie in a time when the pie has been shrinking for a while and it's now dramatically being affected. So just the kind of relevance and the way that these are being driven by use cases that are important to ministries of health and finance, I think has been a real highlight. A couple of quick points on some tensions in how these are approached, because I didn't introduce myself. I'm Owen Brady with the CHAI. So we're working very closely with several governments on how to approach these challenges. And I'll reference back to Tom's half-built house at the beginning. I think building these systems, everyone has to be working off the same blueprints. I think there's tensions, and a couple of tensions that I just want to quickly point out. One is, a programmatic focus for results versus looking sector-wide and looking multi-sectorally and working with finance as well. I think there's been several references to, and Martin has raised the issue of, critical priorities of the health system. Versus taking a kind of broader approach. The other tension, I think, is between short-term and long-term goals, which there's overlap between the two. But I think I think in the past, again, a lot of digital development questions have not necessarily taken a kind of sector-wide or multi-sectoral approach and a multi-use of data approach. And I think, I think these systems have suffered, and we have a lot of legacy systems that are not as useful or maybe not useful at all because of that. And so I think, and another reference to the house, it's not a greenfield site, right? We're not building our ideal house from scratch. There are a lot of systems there, some of which can be still extremely useful if some of these interoperability questions. So I think, these tensions don't have to be, zero sum. I think that this is the approaches that look at registries that exist, look at developing kind of modular, reusable, kind of minimal components to digital systems. Data exchanges that Ethiopia talked about, standards-based data exchanges. This isn't necessarily more expensive it's probably cheaper than developing these, massive systems from scratch, but it also then allows flexibility to use it in multiple ways later. And I think, I also reference back to Martin's talking about the burdens on health workers. A lot of data is being collected, a massive amount of data is being collected. There's huge duplication. So I think approaching how data systems are designed can actually, in a more modular, minimal way, but where you don't waste a lot of this data collection, which I think a lot of it is wasted at the moment, allows you to actually reduce the burden on health, ultimately reduce the administrative burden on health workers. At least that's the vision. Just one final very brief point. I think this has been a fantastic session, but I think it illustrates that there's a lot of learning that can happen between countries and between partner organizations. And I think AFIA is great for that. There are other similar sessions, but I know it's very very exciting work is happening in Rwanda, on the digital front in health and across sectors. And I know of lots of others, including Zambia, Uganda. I probably shouldn't name countries because there are things happening everywhere. And so finding kind of platforms and forums to share this more is great. Also, just want to finally say thanks again, Tom and everybody, and particularly to participants from the government and everybody else who joined today. Thank you.
Okay, thank you very much. Thank you to the presenters. Great presentation. Those online, I hope they're still online, and the colleagues in the room who made the presentations. Thank you to the participants for those very important questions that you asked. And thanks to the team, to ODI and Chai, for the opportunity given to Thinkwell to collaborate with you on this topic. We had very rich presentations. We learned a lot, great example from countries, and one of the positive thing, we have many positive things in this session, but one of the positive thing is to have the countries acknowledging the mistake. Someone said we should not say mistake, otherwise his colleague will score him. But one of the some of the shortcomings of, you know, these intervention in digital health that are happening in countries. So it's very good that we acknowledge what is not working and we see how to improve it. The first part of the discussion was most on, you know, integration, interoperability. And sometimes it looks like we focus more on the process than on the optimum objective. What do we want to achieve with integrating all those systems? We want data for better decision. We want data for better policy. We want to integrate data on supplies, on human resource, on finance. So we all describe, I think in most of our countries, we have this fragmentation. But maybe we have to think, as the colleague mentioned, you know, about cost effectiveness and you know, utilities of having new interventions coming. What do we want to achieve? Maybe first we have to reflect on what are we doing with the tools which are already there. We all acknowledge that there is fragmentation, but are we using the information which is already generated from those finance tools, from the supplies tools, from the HR and service delivery or service utilization? So integration, interoperability is great, but I think the next step for us, for all of us as, you know, technical assistant working with the countries and the ministries is, what should be the optimal path? There is no like a best answer or, you know, to do things, but where should we start? Should we start by ensuring that those individual tools are used? Should we start by making sure that in countries we have policies in place to allow this integration? I think the colleagues from Uganda talk about, you know, having the policy on standardization, and now they have to walk back to try to adjust the tool to make sure that we have the same reporting system and you know, work about around the governance and make sure that the tools align with those new policies. Should we start there? Or should we start with data literacy and digital literacy? Because if we have all these informations and health managers at the district level, at facility levels, are not able to use this integrated information for decision making, are we achieving our purpose? So I think we have also to ask ourselves, should we start with data literacy? Or should we start with digital literacy? Because we have tools that have to be used by community health workers who don't have, who needs, you know, to know how to operate those systems. Should we start there? Because we'll invest a lot of money and a lot of time in, you know, interoperability and having systems in place. But then when we have all those systems talking to each other, people who are in charge of, you know, feeding those tools don't know where to press, where to start. So just, you know, a bunch of reflections. the optimal path. Where should we start? There is no magic answer. There is no wrong or good answer. Each country has his, different contexts. The specificities are different. So I think it's important for us to think about, what do we want to achieve? Not just integrating system for the sake of it, but make sure that when these systems are integrated, data which is generated is quality data and is used for decision making, is used for better policy. That is just, much of reflection that I think it's important that all of us have, and we continue the discussion as, a community trying to improve, quality of data, make sure that the data is available. So thanks to all the participants, it was a wonderful session, and I will pass the mic to Daniel.
Thank you so much. So I'll echo the other speakers in thanking our speakers and our partner countries, and particularly to those who presented reform projects that are still underway and incomplete. As Tom said, I think it's very brave to do that, and actually probably more useful than just seeing a successful end project. And then, yeah, I think what was very reassuring is to see that all the countries are not just approaching this as purely a technical or technological reform. As Owen said, it is very clear that there's a use case in each example, and that really is about addressing real-world functional health system problems, but also that people seem to be bearing in mind the incentives of different agents and how to align stakeholders early in the process, as we saw in Uganda, and yeah, ensuring that data actually meets the needs of users. And then also that data governance seems to be so central, at least in Burkina and Ethiopia. Obviously, this really needs to be a foundational concern to ensure that we have data in unified formats to allow for system integration and make sure that systems are able to speak to each other. And quite a few of the speakers also highlighted the importance of sequencing. Marie-Jeanne also just touched on that. But thinking through what data we want to focus on initially, it's not necessarily possible to look at everything all at the same time. And thinking through what's likely to be most impactful. For example, in Ethiopia, where primary healthcare data has been the initial focus, and trying not to overburden facility staff or compromise data quality. And also the importance of understanding local context was mentioned throughout in terms of infrastructure, connectivity, technical capabilities, and also being realistic about what can be achieved now and what needs to be invested in as a first step. And Marie-Jeanne, you also touched on that. I think what we also need to start considering is how to take this to the next level and actually ensure data informs policy making at all levels. Martin mentioned facility level decision making, but also subnational, national decision making. We're starting to get a glimpse of that in Ghana, but really without a sort of pull for better data from policymakers, the supply and quality of data is never really going to reach its ultimate point. Yeah, just to conclude, I think this is a very, very exciting time for this work and thinking through the integration of financial, non-financial data. Owen said there are lots of countries working on this, but it is still very nascent. There's lots of room for innovation, and now really is the time where we want to be investing in peer learning and experimentation and learning about each other's failures, as has been mentioned a few times. And at OER Global, we are going to be focusing quite a lot on that and trying to build up a network of practitioners working on issues of trying to get better data for better policy. This is a first step in that direction. And we want to keep documenting how governments are approaching these issues so we can enable peer learning. And I also think that will ultimately encourage development partners to start supporting these local solutions and allow governments, as is happening in Ethiopia, to actually drive the direction of these reforms and to take partners along where they want the financing. Yeah, we're also going to be doing some research in this area, including a publication that's going to come out next month on emerging themes in digital public financial management for health, and ultimately sort of developing a typology for digital PFM for health approaches and systems. So going to be very active in this area, and I hope you will all be too.
Thanks, Danielle. I won't attempt to build on that excellent summary of some of the key points that we've covered. But like as Danielle said, I do just want to reiterate that we see how to strengthen health systems, data systems in health, and how to better use them in informing policy and implementation is an emerging area. It is one where we want to build a network of practitioners and document lessons, both from the African continent, but also more globally as well. I'd encourage all of you, Owen talked about needing a platform to share these lessons. At ODI, we have a digital public finance hub, which covers some of these issues from the health sector, but also more widely. So I encourage all of you to look at that and sign up for the updates from it. And that is where we will be putting lessons and case studies and so on as we develop these. And again, please look at it and please do get in contact if you've got interesting work or reforms that you think that have lessons more broadly and that deserve a hearing to inform other countries as well. So it just falls to me now to again thank our speakers. Thanks to Animat and Dimitri online, to Ali and Andrew, and to Hamza, Moritz, and Martin. Thank you to Owen, Marie-Jean, Danielle for helping organise this, and to my colleague Antoine as well, who's been doing a lot of the work behind the scenes to get this arranged for today. And thank you all as participants, because without your participation, without your excellent questions, we wouldn't have half the session that we would have had otherwise. And finally, I'd like to thank the Gates Foundation for their support that enables ODI's research on this topic. So thank you all once again. Thank you to our speakers, and I won't hold you back from your lunch any longer. Thank you.